This is the lecture for breast and reproductive cancer. Breast cancer is not a single disease. It is actually an umbrella term that covers diverse clinical presentations of malignancy within the tissues of the breast. The breast itself is comprised of lobes and ducts. Each breast has about 15 to 20 lobes, and each of those lobes have many smaller sections called lobules. The lobules end in tiny glands that produce milk, or can produce milk. These are all linked by thin tubes called the ducts. Cancerous cells can arise in any parts of the breast. Most of the breast cancers are adenocarcinomas, with about 75 to 90% originating in a milk duct or lobule. They can be either non-invasive, which is known as in situ, or they can be invasive. Breast cancer, again, is the unregulated growth of abnormal cells in breast tissue. It's the most commonly occurring cancer in women, and it is the second leading cause of death for women in the United States. Some of the risk factors for breast cancer cannot be changed, while others, can be changed while others cannot. The unchangeable factors, of course, are age and gender. There are some genetic risk factors that cannot be changed. When there's a family history of breast cancer, women who have denser breast tissue, a personal history of breast cancer, those who've received previous chest irradiation, and menstrual history. Women are 100 times more likely than men to have breast cancer, with the risk increasing with their age. 5 to 10% of breast cancers are believed to result directly from the genetic mutations that are inherited from a parent. Having a first-degree relative with breast cancer doubles the risk, and having 2 first-degree relatives increases that risk 5-fold. Dense breast tissue has more glandular tissue and less fatty tissue, increasing the risk for a woman even more. A woman with cancer in one breast has a 3 to 4-fold increase in risk for developing a new cancer in the other breast or other part of the same breast. Radiation of the chest as a child or young woman for other cancer increases their risk. Risk is greatest for those who have irradiation during adolescent breast development. Women who have begun their menstruating before the age of 12 or who have menopause after the age of 55 are at a slightly higher risk. The thoughts are that it is due to the higher lifetime exposure to estrogen and progesterone. Lifestyle-related factors that can increase the risk include the use of oral contraceptives, not ever having children or having had them after the age of 30, long-term use of hormone replacement therapy, not breastfeeding, heavy consumption of alcohol, obesity because of the extra estrogen stored in the fat cells, and physical inactivity. When we look at the pathophysiology, we look at it as it begins as a single transformed cell. It can be hormone dependent. Carcinoma of the mammary ducts, carcinoma of mammary lobules, or sarcoma of the breast. It can metastasize through the bloodstream or the lymphatic system. Some of the possible causes can include environmental, hormonal, reproductive, and the hereditary factors. As discussed in the opening, most breast cancers are adenocarcinomas and appear to arise in the terminal section of the breast ductal tissue. The most common type is infiltrating ductal carcinoma. Two atypical types are inflammatory carcinoma and Paget's disease. Inflammatory carcinoma is the most malignant form of breast cancer. Edema with dimpling of the skin that results in skin looking like the peel of an orange is usually present. Paget's disease is a rare type and involves infiltration of the nipple epithelium. The most common areas for breast cancer to metastasize are the bone, brain, lung, liver, skin, and lymph nodes. Manifestations of breast cancer can include a non-tender lump, which is most often felt in the upper outer quadrant. They may experience some abnormal nipple discharge. They may notice a rash around the nipple area, and they may have nipple retraction. There can be dimpling of the skin or a change in the position of the nipple. They can experience nipple pain, a scaliness or ulceration, skin irritation, or discharge. The first step in diagnosis is with detection. Any palpable mass requires evaluation. A thorough history needs to be taken, including the risk factors. An actual physical exam, including a breast exam and an examination of the lymph nodes. A mammography needs to be done, and if called for, an ultrasound, a biopsy, and potentially an MRI of the breast if it is indicated. Diagnostic studies will need to be done. If it is suspected in the biopsy, they may choose to do an axillary node dissection. This is often performed to determine if the cancer has spread to the axilla on the side of the breast cancer. The more nodes that are involved, the greater the risk of recurrence. Receptor-positive tumors commonly show evidence of being well differentiated, have a lower chance of recurrence, and are frequently hormone-dependent and respond to hormone therapy. Receptor-negative tumors are often poorly differentiated, frequently recur, and are usually unresponsive to hormone therapy. Sentinel lymph node dissection is less invasive and is usually used more often. For this, a radioisotope and/or blue dye is injected into the affected breast, and intraoperatively it is determined which sentinel lymph nodes the radioisotope or dye is located. A local incision is then made, and the surgeon dissects the blue-stained lymph nodes. 1 to 4 nodes are removed. If they are negative, no further axillary surgery is necessary. If positive, a complete axillary dissection may be done. Tumor size is a prognostic variable. The larger the tumor, the poorer the prognosis. The more the cells are well differentiated, meaning like the original cell type, the less aggressive the tumor is. Estrogen and progesterone receptor status is used for treatment and prognosis. Receptive positive tumors commonly show histologic evidence of being well differentiated, have a lower chance of recurrence, and are frequently hormone dependent and will respond to hormone therapy. When we talk about those tumors that are receptor negative, these are poorly differentiated histologically. They frequently will recur and usually are unresponsive to the hormone therapy. When we talk about ploidy status, this correlates with how aggressive the tumor is. Diploid tumors have been shown to have a significantly lower risk of recurrence than aneuploid tumors. And this is where we talk about when 25 to 30% of metastatic breast cancers produce what we call an excessive HER2. And this is a particular hormone that is produced. And again, if it's a diploid tumor, it is significantly lower risk of recurring than the aneuploid tumors. When there is the presence of HER2, it assists in the selection and sequence of chemotherapy that the patient will get, and it also helps to predict the patient's response to treatment. A patient whose breast cancer tests negative for all three of the receptors, estrogen, progesterone, and HER2, has what we call triple negative breast cancer. This particular subtype of breast cancer accounts for about 10 to 20% of all diagnosed cases. Triple negative cancers have a higher incidence in Hispanics, African Americans, and younger women, and those women who have BRCA1 mutation. And unfortunately, those who have a triple negative breast cancer tend to have more aggressive tumors with a poor prognosis. Non-invasive, which include ductal carcinoma in situ and lobular carcinoma in situ. Ductal carcinoma in its early form is confined to the duct. Prognosis is excellent with a survival rate approaching 100% with proper treatment. It tends to be unilateral, and if left untreated can progress to an invasive state. Patients should discuss options for treatment with their healthcare provider, including lumpectomy, mastectomy with breast reconstruction, radiation therapy, and/or hormone therapy. Lobular carcinoma in situ is misleading in that it is a risk factor for developing breast cancer. It is not known to a pre-malignant lesion, and no treatment is indicated. However, hormone therapy may be utilized as a preventive measure. Invasive ductal carcinoma is the most common. It actually arises in a milk duct that opens onto the tip of the nipple. The malignant cells actually break through the wall of the duct and invade the breast tissue. It commonly metastasizes to bone, lungs, and liver. Invasive lobular carcinoma begins in the lobules or the milk-producing glands. This cancer actually, the cells break out and have the potential to metastasize. It is most likely to occur bilaterally. It will most likely metastasize to the GI tract, peritoneum, and retroperitoneal area, and the ovaries. You'll usually see a subtle thickening in the upper outer quadrant of the breast, and most are estrogen and progesterone receptor positive. In the staging workup, your patient will receive a complete blood count, platelet count. They'll look at the calcium and the phosphorus levels because they are looking to see if there has been some bone metastasis. They're going to look at their liver function test, a chest x-ray, and the patients are going to undergo bone scans, a CT scan, usually chest, abdomen, and pelvis, and an MRI. Again, because they are being evaluated for a thorough workup, looking for any metastasis to any other areas at the time that the cancer is diagnosed. In addition to hormone therapy, they will also look at doing biphosphates to help strengthen and reduce the risk of any fractures in the bones that may have possibly been weakened by metastatic breast cancer. And it can also prevent thinning of bone from treatment with any aromatase inhibitors or from early menopause that is a side effect of the chemotherapy that the patient may receive. These drugs do have some side effects. They can develop some flu-like manifestations and some bone pain. A rare side effect from these biophosphonates is damage to the mandible, which can lead to tooth loss and bone infection. Therefore, all patients taking these medications need to maintain good oral hygiene and regular dental checkups. In surgery, they can do breast-conserving surgery such as a lumpectomy or a partial mastectomy. In a lumpectomy, it usually involves removal of the entire tumor along the margin of the normal surrounding tissue. For patients who are candidates and elect this surgical method, radiation is done to either the entire breast, but now, with the breakthrough of the mammocyte, direct dosing to the tumor bed can be done in a 5-day period. Breast-conserving surgery, if not contraindicated, preserves the breast, including the nipple. Contraindications which would lead to a mastectomy include breast size too small in relation to the tumor to yield an acceptable cosmetic result, multifocal masses, or calcifications. There can also be contraindications for radiation which could lead to a choice for a mastectomy. If the patient has a history of lupus or has had prior radiation therapy in the area. A mastectomy is the removal of the entire breast. A simple or a total does not remove axillary lymph nodes or muscles under the breast. A modified radical mastectomy removes the breast and some of the axillary lymph nodes. Side effects include pain, change in the shape of the breast, the potential for wound infection, and hematoma. If axillary nodes are removed, there is the risk of lymphedema. Please review Table 51-7 on page 1215. The most common options for resectable breast cancer are your breast conservation surgery with radiation therapy, a modified radical mastectomy with or without reconstruction, and early-stage breast cancer patients are your best candidates for either of these treatment choices. Overall survival rate with lumpectomy and radiation is about the same as that with a modified radical mastectomy. Axillary lymph node dissection on the same side as breast cancer is often performed. Until recently, it was the standard of care for invasive breast cancer. When they do perform this, normally they will remove around 12 to 20 nodes. However, if the sentinel lymph node, if they do that and they can identify how many nodes are involved, that helps to preserve a lot of the lymph nodes and helps to prevent a lot of the complications with lymphedema that can occur due to the amount of lymph nodes being removed. Sentinel lymph node, as I said, has replaced the axillary lymph node dissection, which has helped to eliminate some of the complications that occur, especially for those who do not have malignant cells. If once they find sentinel lymph nodes, if there's a lot of malignant cells present, they will be required to do the axillary node dissection. The examination of the lymph nodes helps to provide further prognosis and further treatment information for the patient. When large numbers of lymph nodes are removed, the patient can experience complications of lymphedema because, again, without the lymph nodes present, there is nowhere for that lymph fluid to go. The patient can experience heaviness, pain, impaired motor function of their arm, have numbness and paresthesia of the fingers. When they have surgery on that side, it's very important that they know and get teaching on what they can and cannot do on that side. It is important that they know that they cannot be carrying heavy objects on that side, no pocketbooks, grocery bags, anything like that, no blood pressures done on that arm, no lab sticks, blood draws, IVs started on that side as well, as this can cause further complications. If a fever and a red painful rash can develop, they can end up with an infection of the infected arm. Should the patient develop lymphedema, it's important that we treat them with what we call a decongestive therapy for the patient. We use massage-like technique to help mobilize the subcutaneous accumulation of fluid. This can be accomplished by using compression bandaging, and you can also use intermittent pneumatic compression sleeves. It is important that the arm is elevated at the level of the heart. Sometimes they do use diuretics, and they can use isometric exercises for the patient. And this picture just shows you an example of a patient who's developed lymphedema, showing how much larger the one arm is all the way down to the hand from the excessive lymph fluid that has accumulated. Lymphedema, again, this is just going over what they can experience. It is not always preventable. However, it can be controlled somewhat after surgery or radiation. Again, by doing good patient teaching, and telling them what they need to avoid. No tight sleeves on that arm. Another important thing about doing their exercises, and what to monitor for. When radiation is the primary treatment, it is done after excision of the breast mass. If the tumor is unusually large, radiation can be done prior to the tumor being removed. External beam is most common and is performed on an outpatient basis 5 days a week for 5 to 7 weeks. When lymph nodes are involved, the axilla may be irradiated as well. Fatigue, skin changes, and breast edema may be temporary. Same restrictions regarding lotions, powders, and deodorants apply. On the side of the breast, or the side that the radiation is taking place. They cannot use any types of lotions. They cannot wear deodorant on that side of the arm, and no powders during that time that this is going on. If there are any lotions applied, it has to be water-based lotions, and it cannot be 2 hours prior and 2 hours after radiation treatment. In brachytherapy, which is done via the mammocyte, radioactive beads are actually placed into the balloon and then removed. Treatment consists up to 5 days, and this is what the mammocyte looks like. And actually, where the tumor is removed, they actually insert the mammocyte, and you see the balloon there. The mammocyte stays in place, and they will, when the patient comes in to the radiation center, they blow the balloon up and put the radiation seeds down in there, connected to the machine. It delivers the radiation therapy. The seeds are removed, and then the patient can go on about their day. They get 5 days of treatment, and then their treatment is complete. My mom, when she had her initial surgery and her initial diagnosis and she had her lumpectomy, this was how she had her initial treatment for her breast cancer. She'd had her lumpectomy, they inserted the mammocyte immediately afterwards, and then she had her 5 days of radiation treatment to the area. That way it's able to specifically just treat the tissue that's involved and not damage any of the other tissue around the area. Hormone therapy can also be utilized. It's used to block estrogen activity. It's also used to treat advanced breast cancer and as an adjunct for early stage, as well as preventive. Immunotherapy using Herceptin is used to stop the growth of breast tumors that express the HER2 receptor. Tamoxifen, I'm sure you've heard of, it's been used a great deal. Side effects include nausea, vomiting, fever, chills, weakness, diarrhea, and headache. Herceptin, unfortunately, is cardiotoxic and can cause some more serious cardiac side effects, leading to heart failure. When someone is going to receive Herceptin, they have to have a baseline echo prior to the treatment being started. They receive echoes so many months after the baseline, and then they receive it so many months after treatment is completed, and then they have to have them at least once a year for so many times after that. The aromatase inhibitors actually stop the production of estrogen in postmenopausal women by blocking the enzyme aromatase, which turns androgen into small amounts of estrogen in the body. There are fewer side effects, and the benefits lead physicians to utilize this more for patients. Follow-up care is the rest of the life, must occur at regular intervals. Professional examinations every 3 to 6 months for 2 years, and then annually. They still need to practice monthly breast self-examination of both breast or the remaining breast. Unfortunately, the most common site of recurrence is at the surgical site. Yearly mammography of the remaining breast and breast tissue needs to occur. Nursing care is important. We need to support the patient's psychosocial impact and psychologically, because there is a lot of fear and the threat of death. Having the breast removed and the complications of chemotherapy with the loss of hair affects a woman's sense of self and their relationships with their family, and how they accept themselves and their body image. So it's very important that we help them with that. We need to make sure that we help them restore their arm function on the affected side after they have a mastectomy, and if they've had axillary lymph node dissection. They need to be in a semi-Fowler's position with the arm on the affected side elevated on a pillow. Immediately post-op, even in the recovery room, they need to start flexing and extending the fingers on the operative side, and progressive increase in activity should be encouraged. Post-operative arm and shoulder exercises are instituted gradually at the surgeon's direction. And these exercises are designed to prevent contractures from occurring and to keep muscle shortening from happening. Maintain their muscle tone and improve lymph and blood circulation to prevent lymphedema from happening. We prevent or minimize postoperative discomfort by providing analgesics 30 minutes before the patients to do exercising. And when they're showering and when they can shower, warm water has a soothing effect and helps to decrease joint stiffness for the patient. They need to be instructed to protect their arm from even minor trauma, avoid sunburn. They need to protect from any type of sunburn using sunblock, any type of pinprick. As I said, no toting of any pocketbooks or heavy bags on the affected side. They need to tell their surgeon of any traumas or any sites of any inflammation, and make sure that they understand that they are always at risk for developing lymphedema. This is just an example of some postoperative exercises for someone who's had a mastectomy or lumpectomy. Simply brushing their hair, doing the arm exercises, doing the climbing the wall, the hands over the arm and the hands touching up over the arms. These are all good types of exercises for the patient to do. With someone who has acute lymphedema, complete decongestive therapy needs to be done. Again, it's the massage-like technique to mobilize the subcutaneous accumulation of fluid. We do compression bandaging and may use intermittent pneumatic compression sleeves. This is all to help in moving that fluid where it needs to go. The arm is always at the level of the heart. If needed, we do try and use diuretics, but we're going to try and do the fitted pressure gradient sleeves during the waking hours and doing the compression bandaging to help with that decongestive therapy for the patient. We're now going to move into the female reproductive cancers. We're going to start with cervical cancer. The two main types of cervical cancer are squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma is responsible for the majority of the cervical cancers that you see or are diagnosed on patients, and those typically occur in the transformation zone of the cervix. Adenocarcinoma accounts for about 20% of cervical cancers and is more common in younger women. This is the type that arises from the mucus-producing gland, and it's associated with HPV and oral contraceptive use. And this is just a picture giving an example of what the pre-malignant cells and malignant cells look like. And that's just showing you, if you were looking at a cervix, the ectocervical lesion that you would see on the patient. And there's a really good picture. That's a pretty advanced cancer on the cervix that your picture is showing in your book on page 1256. Cervical cancer, again, the most significant risk factor includes infection with HPV. It is present in 99% of the cervical cancers that are diagnosed. First intercourse before the 16 years of age, those who've had multiple sexual partners with a history of STIs and infection with HIV are higher risk for developing cervical cancer. Other risk factors include those who smoke, because smoking causes changes of all cells in the body, poor nutritional status, obesity, multiple pregnancies, long-term use of birth control pills, and a family history of cancer or cervical cancer. Precancerous changes and early cervical cancers doesn't usually cause pain or any other symptoms. As the dysplasia gets worse, women may notice that they have bleeding that occurs between their menstrual periods or bleeding after sexual intercourse or pelvic exam. Increased vaginal discharge can be noticed, as well as they may experience some pelvic pain or pain during intercourse as well. If it is a locally advanced disease occurring when surrounding structures are invaded, they may have pain in the legs, back, or pelvis. They can have bleeding from the rectum or blood in the urine. Once the cancer has metastasized, all these symptoms may be experienced, as well as bone pain, fractures, or lung problems that are associated with the spread to these areas. A Pap test is the microscopic examination of cells from the vagina or the cervix. The test results may fall into 6 categories. They could be normal, they could be atypical squamous cells of undetermined significance, atypical glandular cells of undetermined significance, low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, or cancer. If a Pap test returns with an ASU-US result, the standard of care is to repeat the test in 4 to 6 months, or to test for HPV. If the HPV testing is positive for a high-risk type, then a colposcopy is indicated for the patient, as well as an endometrial biopsy may be indicated for those women who are older than age 35, or if they have expressed that they have had abnormal bleeding. If endometrial cells are present, biopsy is required, as these are a precursor for adenocarcinoma. This is the picture from your book, and as I said, this is pretty much looking like a more advanced cancer, because you can see some other areas of tumor other than the lesion that's there on the cervix. A colposcopy is the actual examination of the cervix using a binocular microscope and a special staining. A biopsy of the abnormal areas is usually done at the same time that they're doing this. After the cervical cancer is diagnosed, it is then staged using either the International Federation of Gynecology and Obstetrics system, or simply using the TNM system. Unlike the staging system used for other cancers, the FIGO system doesn't account for spread of the cancer to local lymph nodes when that is utilized. Women with low-grade cervical dysplasia may be given the option of no treatment, because an estimated 50 to 70% of these lesions can spontaneously resolve. A Pap test will be necessary every 6 months. If they do not resolve, further treatment can be necessary after that. Cryotherapy or freezing can be used to treat those lesions because of its reliability, its ease of use, its very low cost, and it has a low rate of complications. It is what is most likely used for low-grade dysplasia. A LEAP actually uses a thin wire loop through which an electric current is passed. Turning the loop into an effective cutting tool is where they actually remove the lesion. They slice off that area on the cervix where the lesion is at. Laser ablation is indicated for lesions that extend into the cervical canal, and a cold knife conization uses a scalpel to actually remove the portion of the cervix that contains the abnormal cells. If invasive cancer is found, the treatment is usually a total hysterectomy being performed either abdominally or vaginally without removal of the ovaries for the patient. If the cancer is more advanced, the patient may require a radical hysterectomy to be performed. This removes not only the body and the neck of the uterus, but also the upper third of the vagina and the ligaments on either side of the cervix. The goal is to clear the tumor with a good margin of normal tissue around it. If cancer is detected after it has grown to the ligaments next to the cervix, it becomes difficult to get a good margin, and surgery may be deferred, and the patient may be treated with a combination of chemo and radiation. The decision will depend on age and medical condition of the patient. These patients, if they're a much more advanced cancer, are referred to surgical gynecologists who specialize in, or surgical gynecological oncologists that specialize in this for treatment. Your regular gynecologist usually will refer them further for a more specialized treatment. This is just showing your total hysterectomy. The dotted lines basically show you where the removal of the different areas are for the uterus and the cervix removal on the pictures. And this is just showing the vaginal hysterectomy. When we talk about endometrial cancer, it is the most common gynecologic malignancy. It has a low mortality rate, and there's about a 95% survival rate. There are some major risk factors that occur. Increasing age, nulliparity, late menopause, obesity, smoking, someone who's a diabetic, and of course having a personal or family history of non-polyposis colorectal cancer is also linked to endometrial cancer as well. The first sign of endometrial cancer is abnormal uterine bleeding, usually in those women who have already gone through menopause. Pain is actually late in the disease process. Molecular markers can be helpful to help identify those people who are at high risk. They include the p53 and p16 overexpression, and the expression of estrogen or progesterone receptors by the tumor cells. The absence of these, one or both of these receptors, is a poor prognostic indicator. Endometrial biopsy is the primary diagnostic tool that is done. Treatment is a total hysterectomy with bilateral salpingo-oophorectomy, and they will do lymph node biopsies. Surgery can be followed by irradiation either to the pelvis or abdomen externally or intravaginally to decrease local recurrence. Treatment of advanced or recurrent disease is difficult. Progesterone hormonal therapy, Megace, is the treatment of choice when the progesterone receptor is positive and the tumor is well differentiated. Tamoxifen, either alone or in combination with progesterone therapy, is also effective in advanced or recurrent endometrial cancer. Chemotherapy is considered when progesterone therapy is unsuccessful, and they can use agents such as what is listed here for that. With ovarian cancer, this is the malignant neoplasm of the ovaries. There are about 21,000 new cases and about 16,000 deaths annually. It occurs primarily in women of white descent between the ages of 55 to 65 years of age. Women with mutations in the BRCA genes have an increased susceptibility to ovarian cancer. Greatest risk being those who already have a family history of either breast or colon cancers, especially hereditary non-polyposis colorectal cancer. Also, those women who have never been pregnant are also at a higher risk. Other risk factors include age, if they consume a high-fat diet, greater number of ovulatory cycles, the use of hormone replacement therapy, and those who have used infertility drugs. Associated lower risk are those who have been on oral contraceptives, women who breastfeed, those who've had multiple pregnancies, and those who were younger at birth when they gave birth to their first child. For some reason, these factors seem to have a protective effect because they reduce the number of ovulatory cycles, and so they reduce the exposure to estrogen that these women have had. 90% of ovarian cancers are epithelial carcinomas from malignant transformation of surface epithelial cells. Germ cell tumors account for 10%. Histological grading is important as a use for prognostic determinants. Tumors are graded from a 1 to a 3 according to how the cells are differentiated. Ovarian cancer can metastasize directly by the shedding of the malignant cells, and they frequently implant in the uterus, bladder, bowel, and omentum, and metastasize very easily through the lymphatic system. Clinical manifestations: the patient may complain of feeling bloated. That's usually one of the first complaints, feeling like their pants don't fit anymore, but they haven't gained any weight, they just feel bloated. General abdominal discomfort, some pelvic pain, urinary urgency or frequency. They may feel full very quickly. Symptoms can be vague in the early stages. They can be nonspecific, but they do warrant being evaluated further, especially if they occur daily for at least 3 weeks. Women who have one or more of these types of symptoms, especially if they are new, persistent, or they start to get worse, need to see their healthcare provider for further evaluation to occur. Later signs, they start having the increase in the abdominal girth, or if they start having unexplained weight loss or gain, or start having menstrual irregularities that occur. There are no screening tests that exist as of right now. Yearly bimanual pelvic examination should be performed as the early stages are usually asymptomatic. Postmenopausal women should not have palpable ovaries, so if someone is postmenopausal and you can palpate their ovaries, that is not a good sign at all. Abdominal or vaginal ultrasound can also be used to detect any ovary or ovarian masses, an exploratory laparotomy to help diagnose and stage, and an OVA1 test can be done. This uses a blood sample to test for levels of 5 different proteins that change as a result of ovarian cancer. It is not intended as a screening, but for a definitive diagnosis of ovarian cancer. Screening for high-risk women should include a CA-125, an ultrasound, and a yearly pelvic examination. CA-125 has been found to be positive in 80% of the women who have ovarian cancer. However, levels of CA-125 may also be elevated with other non-ovarian malignancies or with benign conditions such as fibroids or endometriosis. Clinical trials are actively investigating serum biomarkers that may detect ovarian cancer at an early stage, and currently only 20% of ovarian cancers are diagnosed at an early stage. Women need to be counseled who are at high risk regarding their options, an oophorectomy, oral contraceptives. An oophorectomy will reduce the risk but will not eliminate the possibility of the disease. Ovarian cancer staging is critical for guiding the treatment decisions. Stage 1 describes the disease limited to the actual ovaries. Stage 2, the disease is limited to the true pelvis. In a stage 3, the disease is limited to the abdominal cavity. And in a stage 4, there is actual distant metastatic disease. And the overall survival rate is about 89% with early disease, 36% with local spread, and 17% with distant metastasis when that has occurred. In stage 1, when it's limited to the ovaries, the treatment includes a total hysterectomy, bilateral selfing oophorectomy. They will evaluate the remaining tissue in the abdomen and pelvis, and we'll be looking at some chemo or intraperitoneal radioisotopes if it's poorly differentiated. In stage 2, the treatment will include external abdominal and pelvic radiation, intraperitoneal radiation, systemic combination chemotherapy after tumor-reducing surgery. After completion of systemic chemotherapy in the patient who is clinically free of symptoms, a second look surgical procedure is often performed to determine whether any evidence of disease can be found. This option does not necessarily improve the outcome. If no disease is found, the patient is monitored for recurrent disease, so they will still need follow-up after all the procedures are done. This is just talking about some of the chemotherapy agents. There can also be surgical debulking that can be done in addition to chemotherapy agents. They can also do intraperitoneal chemotherapy, and you'll learn more about that when we do just the general oncology lecture. In vaginal cancers, primary vaginal cancers are rare. Peak incidence is between 50 and 70 years of age, and it's usually the second site or metastasis of other cancers. It's usually a squamous cell carcinoma, and the treatment will depend on the type of cells and at what stage. Usually it can be treated with surgery and with radiation, and usually it's done with the radiation implants. Vulvar cancer, again, it's relatively rare. It's similar to cervical cancer. Pre-invasive lesions referred to as vulvar intraepithelial neoplasia precede invasive vulvar cancer. Patient can complain of itching or burning, pain, bleeding, or discharge. Women who are immunosuppressed or who have diabetes, hypertension, or chronic dystrophies are the higher risk patients for this type of cancer. There are some HPV subtypes that have been found in some of these cases. The diagnosis will determine what's going to be done about it, and they usually eradicate the lesion with 5-FU or by surgical excision. If the lesion is extremely large, it may require more extensive surgery and skin graft. I'm going to also post 2 articles that help support and give more information for this lecture on the breast cancer and the reproductive cancers. So thank you.